Welcome to the Creative Commons RX podcast. Before diving into this episode, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
Welcome back to The Deep Dive. Today we are focusing on a class of medication used by, well, hundreds of millions of people globally, anti-diabetic agents. We're talking about the big three, metformin, sulfonylureas, and of course, insulin.
These medications are the absolute bedrock of managing blood sugar. But when they leave their therapeutic lane, whether that's an overdose, an accident, or just compounding health issues, their function transforms into a profound toxicological crisis.
Their daily utility almost acts like a veil, hiding the fact that these common pills and injections can trigger, catastrophic cellular energy failure or a prolonged refractory sugar coma.
Exactly.
So our mission today is to go past the prescribing basics. We are extracting the critical, nuanced knowledge on two specific, pretty deadly syndromes: metabolic acidosis with an elevated lactate concentration, or MLA, and severe protracted hypoglycemia.
And we really want to arm you with the diagnostic and management tools that are essential when minutes count, including this surprise fact that the very treatment we use for a sugar crash, dextrose, can actually perpetuate the crisis.
It can make it worse.
It can stimulate the patient right back into a dangerous rebound hypoglycemia.
Okay, let's unpack this and start with the anchor drug, metformin. It's been around forever, yet its full toxicological profile, its dark side, really only emerges under specific stress.
Metformin is fascinating because its effects are so far-reaching. We know it works primarily by inhibiting the liver's ability to produce glucose, a process called gluconeogenesis. It does this, in part, by inhibiting mitochondrial glycerylphosphate dehydrogenase.
That's deeply specific. Does that specific inhibition explain why Met-OA is so tied to energy depletion rather than just simple lactic acid production?
Absolutely. The mechanism goes even deeper.
Yeah.
Metformin also inhibits mitochondrial complex I. This activates AMPK, which is a master regulator of cellular energy.
Okay.
And while the overall effect is beneficial, it enhances glucose uptake in muscle, increases GLP-1 sensitivity. That mitochondrial interference is the black box that leads to MLA.
So if you stack metformin on top of a patient who already has poor tissue oxygenation,
you have a disaster brewing.
Before we delve into that disaster, we need to address the official terminology. Many people still call it metformin-associated lactic acidosis. You prefer the term metabolic acidosis with an elevated lactate concentration, MLA. Why is that distinction so crucial?
Well, it's not just semantics, it's pathophysiology. Lactic acid production on its own doesn't necessarily create hydrogen ions and cause severe acidosis.
Right.
The real problem in MLA is the failure of oxidative metabolism because of the drug's effects on the mitochondria. When that fails, your body is forced into energy production via ATP hydrolysis, and that process generates excess hydrogen ions.
So the elevated lactate is a signpost, but the impaired oxidative metabolism is the engine driving the acidosis and the systemic collapse.
Well, that's it, exactly.
This must make early diagnosis extremely difficult, especially since metformin has, known therapeutic side effects.
It does. Early symptoms of MLA are frustratingly vague. Abdominal pain, nausea, general malaise.
Things that could be anything.
They overlap entirely with the GI discomfort that many patients experience when they first start taking the drug. By the time you see the classic severe symptoms confusion, mental status depression, and hypotension, you are already dealing with a late-stage, life-threatening crisis.
And speaking of classic toxicology, let's clear up that common mnemonic, cat mud piles.
Yes. If you're a learner out there, do not assume the M stands for metformin. It is not.
That doesn't.
No. The P in that classic list stands for fenformin. That was metformin's much older, far more dangerous relative that was pulled from the U.S. market back in 1977.
Right.
The truth is, metformin-associated MLA is thankfully 20 times less common than fenformin's historical problems. It's a powerful historical distinction.
That puts metformin's risk into context. But what are the triggers that allow this relatively rare MLA event to take hold?
MLA almost always requires an underlying condition that disrupts metformin clearance. The drug is 100% renally eliminated, so the number one risk factor is profound renal dysfunction.
So if the kidneys stop working,
The drug concentration rapidly escalates and saturates the mitochondria systemically.
that makes sense. The kidney status is the clearance gate. What happens when that clearance gate suddenly slams shut due to something like, say, contrast imaging?
That's a critical clinical point. The use of iodinated contrast material for diagnostic imaging is notorious for inducing acute renal dysfunction. This is why the American College of Radiology explicitly recommends discontinuing metformin temporarily, specifically for 48 hours. If the patient's eGFR is already below 30, you have to anticipate that risk.
So we have a patient in crisis severe refractory metabolic acidosis, dropping blood pressure. Standard supportive care, like fluids and vasopressors, is failing. What is the ultimate intervention here?
When you reach refractory acidosis, the only way to quickly reverse the critical acid base status is through extracorporeal treatment, or ECA, typically hemodialysis.
Okay.
The grim reality is that prognosis is tied directly to how sick the patient is, from the acidosis mortality associates with lactate levels and pH, not just the concentration of metformin in their blood.
You mentioned an important work group that defined clear triggers for initiating ECA. If I'm the clinician in that intense moment, what are the hard lines that tell me I need to commit to dialysis now?
Think about the gravity of these numbers.
Huh.
You initiate ECA if the lactate concentration is greater than 20 millimoles per liter.
That is profoundly high.
It is. Or if the pH is at or below 7.0, that's a profoundly unstable, actively dying environment. If the patient is in shock or has a decreased level of consciousness that isn't responding to standard care, you need ECA.
And you continue that aggressive treatment until the patient is pulled back from the brink.
Exactly. You keep going until the lactate drops below 3 millimole and the pH stabilizes above 7.35. That process can take hours, but demonstrates how critical this rapid correction is for survival.
It's clear NLA is an acid-base crisis fueled by cellular energy failure. But now we pivot to a fundamentally different yet equally deadly threat: the severe, prolonged sugar crash caused by hormonal overload.
This is a scenario where the patient isn't running out of energy. They have too much insulin demanding that energy be stored in the wrong places, leading to neuroglycopenia starvation of the brain.
Let's start with sulfonylureas, the insulin secretagogues. They force the pancreas to release insulin regardless of the actual glucose level. How do they perform that override?
Imagine the pancreatic beta cell as a vault that holds preformed insulin. Normally, high glucose acts as a signal to open potassium channels, which eventually leads to insulin release. Sulfonylureas act like a skeleton key.
A skeleton key.
They bind directly to the sulfonylurea receptor, or SUR, on those channels.
What happens when that key turns?
It forces those channels closed. When the channels close, the cell membrane depolarizes. That depolarization is the critical trigger that opens voltage-gated calcium channels. Calcium floods the cell, and that influx triggers the massive forced release of preformed insulin.
So the body's natural glucose sensing mechanism is completely bypassed.
Completely.
That's a potent mechanism. But the resulting crash isn't just a quick hit, is it? We are talking about hypoglycemia that is often prolonged and delayed.
That is the major clinical headache. Many of these second-generation drugs, like glyburide and Glampard, have half-lives approaching 24 hours. The duration of action is further extended by enterohepatic recirculation.
You mean the drug recycles itself?
Essentially, yes. It's processed, excreted into bile, and then reabsorbed in the gut. If a child, for instance, accidentally ingests one of these pills, that long half-life means we generally recommend hospitalization for a full 24 hours of observation.
That's a long time for observation, but skipping it is gambling with recurrence.
Exactly. The delayed onset risk is huge. You might treat the initial symptoms only to have the drug start recirculating hours later, crashing the sugar again while the patient is at home.
Now, moving to insulin itself, an overdose causes 95% of related emergency hospitalizations in older adults. How predictable is the severity?
It is shockingly unpredictable. I mean, we have records of people surviving massive self-injections, thousands of units, while others suffer lethal complications from much smaller amounts.
So it's not about the dose.
Mortality is consistently linked less to the raw dose and more to the delay in recognizing the hypoglycemia and getting adequate treatment started.
Even short-acting insulin can cause prolonged and delayed hypoglycemia. Why would something designed to be fast-acting create this long-lasting crisis?
It's the pharmacokinetics of subcutaneous administration. It creates a slowly absorbed insulin depot. Essentially, you have a reservoir of active insulin sitting under the skin being absorbed over time.
Right.
And crucially, the physiological state of the patient makes it worse. If the patient is already hypoglycemic, their sympathetic nervous system response reduces blood flow or perfusion to the injection site.
So the lack of blood flow means the insulin is absorbed even slower, creating an unpredictable time-release reservoir.
Precisely. That long-term subcutaneous depot is why recurrence is so common. One study showed a 41% recurrence rate, sometimes happening up to 39 hours after the initial treatment was given.
Wow.
You treat it, it goes away, and then the reservoir releases another wave.
This brings us to the treatment paradox. You have to give IV dextrose immediately to save the brain, but that same dextrose triggers a vicious cycle.
That's the tightrope walk. Immediate, rapid intravenous dextrose is non-negotiable for the acute crisis. However, if the patient still has high levels of active sulfonylurea, that surge of blood glucose triggers the pancreas to dump even more insulin into the system.
It's an overreaction.
A huge one. This leads directly to rebound or reactive hypoglycemia once the initial dextrose bolus is metabolized. Cautioning against a routine, constant dextrose drip is vital because it can just feed that cycle.
So we need something that can break the cycle and turn off the faucet of excess insulin. That's where octreotide comes in.
Octreotide is the essential targeted solution here. It's a synthetic analog of somatostatin, and it works by going directly to the beta cell and inhibiting calcium entry. By blocking that critical calcium influx, it suppresses the release of insulin.
It just turns off the tap.
Exactly. It's turning off the forced release mechanism.
And what's the standard regimen for octreotide?
The standard adult dose is 50 micrograms subcutaneously every 6 hours, typically for 24 hours. For children, it's 1 to 2 millisecunds every 6 to 8 hours. And we prefer it significantly over older agents like diazoxide, which carries serious risks of profound hypotension.
But even octreotide with its targeted action can be outlasted by these long-acting pills.
It can. Octreotide's effective duration is only about 6 to 12 hours. Since many sulfonylureas have effects that easily exceed 12 or 24 hours, you have to maintain vigilance. The drug's action can absolutely outlive the octreotide dose.
So you need continuous monitoring.
Absolutely. The clinical rule of thumb is, don't trust a patient with a sulfonylurea overdose until they have demonstrated stable euglycemia normal blood sugar for at least 12 hours after the last dose of octreotide.
Let's pivot now to the final and perhaps most crucial diagnostic piece of the puzzle, using C-peptide as the critical tool for forensic toxicology.
This is where we play detective. When a patient arrives with low glucose and high insulin, the immediate question is, was this insulin injected or was it produced internally?
Because the management pathway changes completely based on that answer.
Completely. Are we treating an accidental injection or a hyperstimulated pancreas?
And C-peptide is the key differentiator here. Explain the chemistry of why C-peptide is so reliable.
Well, insulin is initially manufactured in the pancreas as a larger molecule called proinsulin. To create active insulin, the proinsulin is cleaved, and two products are released simultaneously and in equal amounts: active insulin and C-peptide.
Okay.
The crucial distinction is that while the liver quickly metabolizes and clears the active insulin from the bloodstream, it does not clear C-peptide.
So if I'm running this lab, a low C-peptide is the equivalent of forensic evidence proving this was a syringe problem, not a pancreas problem. Is that result ever misleading?
It is highly reliable in this context. It tells you exactly how much endogenous insulin your patient's pancreas has made. That gives us our 3 critical diagnostic patterns.
Give us the patterns.
Pattern 1. If the patient has an exogenous insulin overdose, an injection, you will find high insulin levels, but the C-peptide will be low or suppressed.
The body saw the high insulin and shut down its own production.
Right. High insulin, low C-peptide, syringe confirmed. Pattern 2.
Sure.
If the cause is a sulfonylurea overdose or an insulinoma, a pancreatic tumor, both of which stimulate internal production, you will see high insulin and high C-peptide.
So high C-peptide means the pancreas is involved, but now we have a tie, a pill or a tumor. How do we break that tie decisively?
You need a definitive second-line test. The most straightforward method is to test for sulfonylurea metabolites in the urine to confirm drug exposure. But you can also use the octreotide suppression test that we just discussed.
The same octreotide we use for treatment.
Exactly. If you administer octreotide and the insulin levels remain stubbornly elevated, that strongly suggests an insulinoma, as the tumor cells are often resistant. But if the patient's insulin levels decrease rapidly after octreotide, it confirms a sulfonylurea overdose.
That system, the reliance on a molecule that the liver doesn't clear to differentiate internal versus external causation, is incredibly elegant.
It connects mechanism, pathology, and management beautifully.
Let's wrap up this deep dive with the key insights we want you, the learner, to carry forward.
First, remember that metformin toxicity, MLA, is highly dependent on underlying renal dysfunction. MLA is a catastrophic acid-base crisis, and when it is refractory, advanced management via extracorporeal treatment is not optional, it's essential.
Second, the major threat from sulfonylureas and insulin is the risk of delayed and prolonged hypoglycemia. This means that the required observation period up to 24 hours, especially for children, is mandatory, regardless of how good the patient looks after initial stabilization.
Third, treating the crash is complex. Remember, the dextrose you give to save a patient from a coma is the same dextrose that triggers the next crash. Octreotide interrupts that vicious cycle, making it the essential targeted countermeasure.
And finally, C-peptide is your forensic tool. It differentiates between exogenous insulin, low C-peptide, and an internally hyperstimulated pancreas, high C-peptide. That distinction informs every subsequent management decision.
This deep dive really reinforces that knowledge is the critical antidote in toxicology. It shows that even seemingly common decades-old medications hide complex, life-threatening mechanisms that demand specialized and sometimes counterintuitive management. The true depth of toxicology lies in anticipating not just the drug's action, but the body's complex, often fatal counterreactions to it.
Something to mull over until our next deep dive. If we know that metformin is eliminated renally and MELA is tied to clearance failure, what is the safest and most effective strategy for managing diabetes in a patient already suffering from chronic, severe kidney disease? The answer lies in those other drug classes we didn't even cover today. We'll save that for next time.
This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.